Welcome back to Fantasy Therapy. I am Dr. Jordan Soper, a board-certified behavioral and cognitive psychologist and a certified sex therapist. I am a giant media nerd. I love movies, TV, I love nerdy things, geeky things. So I wanted to really take two things that I love, which is media and psychology and mental health, and blend them into one. And this is where fantasy therapy came into fruition, or was born out of, the idea of how our mental health conditions portrayed and displayed in media, and being able to identify in what ways mental health symptoms or different patterns are exhibited in media portrayals, and then being able to take that as a clinical lens to show as an example of how would you actually treat that condition in the mental health space. So for today on the docket is going to be Dr. Kevin Casey from the show Scrubs, where we're actually going to be looking at his OCD, so his obsessive-compulsive disorder, what that is, how we treat it, and how we can treat it with him.
Super Doc! Super Doc. Fine. A super doc with obsessive-compulsive disorder.
Okay. How hard can it be for me to step in here left foot first and simultaneously exhale as my right foot plants?
So what you notice Dr. Casey experiencing is something called obsessive-compulsive disorder. And at its very core, what OCD is a neuropsychiatric condition in which a person experiences intrusive, unwanted, and uncontrollable, repetitive, intrusive thoughts, images, or fears that then causes such a high level of distress that it results in high levels of repetitive compulsive patterns of behavior or mental compulsions. What you just saw him do when he walked into the hospital, that is a form of a behavioral right the first time. So he has to do it again and again and again until he gets it right. This is a core feature of OCD, where not only is the person experiencing high levels of distress associated with the obsession that is occurring, but they are also engaging in compulsive patterns of behavior in a way to neutralize or undo or respond to the distressing experience of the obsession. And if it's not done just right, you gotta do it again and again and again. And a lot of people may have experienced, or at least seen in the media, whether it be through this episode of Scrubs, or whether it be through Monk, or in Glee, or in Grey's Anatomy, or in Girls, you may have seen experiences of rightness, or repetition, or cleanliness, or cleaning. A lot of people are somewhat exposed to contamination OCD, ritualization with cleaning, repeating, rituals, doubting. A lot of people will assume that this is what OCD looks like. This is what I like about this episode, is that this is a more accurate portrayal of not only what OCD is from a behavioral standpoint, but how freaking distressing it is when you're not able to engage with the compulsive behavior, or how distressing it is when the obsessions just keep on engaging and keep on hitting you and keep on overwhelming your life. This is something that does a really good job of highlighting how absolutely distressing, overwhelming, and debilitating OCD actually can do. It's not a personality quirk. It's not something that's, oh, it's cute, I like symmetry, or I have to do it a few times. It is, I have to do this because if I don't, ... And that ... is totally unacceptable and very fear-based for the person. It isn't a fun personality quirk that someone experiences. It is a debilitating neuropsychiatric condition, which luckily has some really great treatment options connected to it, which do not include shaming the person for having those experiences in the first place. So if I was privileged enough to have the opportunity to work with Dr. Casey, we would be doing some hardcore ERP, or what is called exposure and response prevention treatment for his OCD. And what ERP is a formalized, structured type of psychotherapeutic approach to the treatment of OCD. And we do this by exposing the person to the feared stimuli and provide an opportunity for them not to engage in their ritualization, not engage in whatever that response is. The goals of ERP are to reduce the person's experience of distress when confronted with that stimuli. So take, for example, when he's engaging in the hand washing.
Hey, give me a minute, will you?
No, Kevin, I have to talk to you right now. Vader's cool too.
I'm sorry, Look, I spent the last few days meeting new people and trying to get used to this place, and I'm stressed and I'm fried. And I just want to go home. But here's the punchline. Even though my last surgery was 2 hours ago, I can't stop washing my damn hands.
You notice it's compulsive. He has to, he has to, he has to. So what ERP would do for him is I would expose him to a variation on his hand washing and then engage in a removal of the response. In this case, the repetitive hand washing. That is what ERP is designed to do, where you expose a person to a stimuli or the change in their ritual and then not engage in whatever that responded behavior is. In this case, it's hand washing. Now, the goals of doing this are not to torture him. The goal is never to torture him. Trust me, his OCD is already torturing him enough for everybody involved. It is to intervene or break the OCD cycle that is going on right now. Because you'll notice when there's the obsession that occurs, the distress that it experiences is so high that the person has an impulse or a need to engage in the compulsive behavior to make that distress go away in some fashion. That's where the relief kicks in. You at least get a temporary smidge of relief, but then that just keeps that cycle brewing, because then the obsession is more likely to occur again. And then because the compulsion has already happened once, again. OCD has a connection with both biology and learned behavior. So a lot of what we would do in treatment with Dr. Casey would be to break the paired association between whatever that obsession is and the distress that it causes. Because right now, they're hanging out with each other. The way in which we do that is to have him no longer engage in the compulsive behavior that's making that paired connection even stronger. So the way that you would approach this case from an ERP perspective would be to identify what the obsessions are, what is the fear associated with the obsession, what are the current ritualized or repetitive patterns of compulsive behavior that are connected to those obsessions, and then to identify what are those physiological and cognitive reactions that the person is experiencing that they are trying to reduce by engaging in the compulsion. Being able to identify specifically for him what is the specific obsession that he is experiencing, and to be able to alternate the way in which he is engaging in the ritual. This might be he only gets to wash one time, or he might only get to wash at a certain speed, or he gets 2 washes and then we have to literally walk him away from the sink. Now, when I say that, some people are like, well, can't they just do it themselves? Bitch, if they could, they would. One of the things that we really want to keep in mind when we are working with the patient, like Dr. Casey, is what we call a case conceptualization. Really understanding how we are approaching the person, and what we want to take into consideration is past experiences. Has this person experienced any workplace trauma? What's their trauma history? Any cultural factors that might be important to take into consideration? In the clips, we're really seeing the manifestation of his OCD symptoms, but part of the role as working with a clinician is understanding the origin and the maintenance factors associated with the symptoms by being able to take that person's individual history into consideration of what factors might have led to the development and maintenance of these particular patterns of distressing symptoms to the person. So for healthcare workers, that's not an uncommon experience where they might have had a case that went negative, or they might have had a thought about, well, what would happen if that case goes negative, or there's a traumatic experience connected to it, or even a history of prior experiences with counting or bad numbers or magic numbers. So whenever we are developing a case conceptualization and a diagnostic model of a patient, in this case, Dr. Casey, being able to take those individual cultural variables into consideration is vital for not only understanding what the symptoms are doing to this person, but being able to integrate their individual person-centered approach into their care, so we are all on the same page to kick some OCD booty. together. So when we're looking at ERP, it is engaging in interactive collaborative treatment where the patient, in this case, Dr. Casey, would actually be doing this in session with myself as a clinician. That is where you're able to practice these types of changes in the patterns of behavior in a safer, controlled space to be able to get those reps in of how do you practice over and over and over. We would not necessarily initially do this in his workspace, even though in the clip we see it occurring and causing a lot of distress in his workspace. We would actually practice it here in the therapeutic space or here in the therapy room. We have bathrooms, we have a sink. In the kitchen, we're able to practice what would it be like to change and alternate that OCD cycle by doing something different than the currently engaged compulsive patterns of behavior. This is going to make him anxious. That's kind of the point, because our goal is to expose him to a stimuli, engage in avoidance of his currently engaged rituals so he can learn to sit with that level of anxiety. He can give himself an opportunity to reduce that level of anxiety that he's feeling in those moments. The more and more reps we get of that, the less and less and less power the OCD is going to have over him. And honestly, that is kind of the goal, because I don't want him compulsing 2 hours after his surgery is done or having to turn on and off the light switch so many times to prevent something from occurring. It's part of the ways that we treat OCD is sitting with uncertainty, being able to learn ways to intolerate the uncertainty of what will happen, or I don't know what will happen if I don't engage in this compulsion. That is part of what we are going to find out together. So I would have loved the opportunity to work with Dr. Casey utilizing an ERP or exposure and response prevention approach to reduce the intensity, the frequency, and the severity of his OCD symptoms. If you would like to learn more about ERP, check out the link right here above. And if you're interested in learning more about OCD, I got some videos for you right here. If you would like even more resources and information about OCD, ERP, and anything related to this particular topic, check down in the description below. I got a bunch of different links, different organizations who I highly recommend if you'd like to learn more. So, who should I therapize next? Who would be a character, a fictional character, by the way, that you would love a psychologist's opinion on their mental health? Put that down in a comment below, and don't forget to like, comment, and subscribe. I'll see you later.